Hey everyone, my name is Eric Norman, and I'm a physical therapist. And shortly we'll be joined by my colleague Christian Jorns, who is also a physical therapist. And we want to welcome you and thank you for listening to the Flex Metal podcast today. Shortly we'll be joined by a very special guest who we're very grateful that he gave us his time to do this podcast, and that would be Dr. Michael Gordon, who is a sports medicine and orthopedic surgeon out of the Milwaukee Orthopedic Group in Milwaukee, Wisconsin. Today we talked about the ACL, surgery, rehab, everything that goes along with it, and got his take on some different questions that Christian and I had. So felt it was a really great podcast, a lot of good learning experiences to be had. So hopefully you all enjoy it, and thanks again for listening. Hey everyone, and welcome to the Flex Metal podcast. Today we have with us Dr. Gordon, very special guest, and he's been willing to give us his time today to answer a few questions. So we're super grateful for that and super excited to get into it. So, Dr. Gordon, how's it going today?
That's good. It's been a nice morning, nice crisp Milwaukee morning. Great run down on the lakefront, so it's a good start.
There you go. Awesome. Love to hear it. So just real quick for the listeners that might not know your background here. So Dr. Gordon originally earned his bachelor's degree in biology at the University of Pennsylvania. He then went on to earn his medical degree from Harvard Medical School in Boston, Massachusetts. After that, he went on to perform general surgery internship and orthopedic surgery residency at Rush Presbyterian St. Luke's Medical Center in Chicago. After that, he went to do his fellowship in sports medicine at the New England Baptist Hospital in Boston, Massachusetts. After this, he went on and passed his board certification in orthopedic surgeon, where Dr. Gordon scored in the top 3% nationally. So for the listeners, that means he probably doesn't know what he's talking about when we're talking about orthopedic surgery. So with all that, Dr. Gordon, I know it's a lot of professional stuff. Is there anything else related to that, or maybe not along more of the professional stuff, maybe more personal stuff that you want to share with the listeners before we move forward?
Well, one, thanks for having me on, guys. I appreciate it. Always fun to get a chance to talk with the therapy folks that really take care of our patients and that make us look good. So we appreciate that. I've been very, very fortunate with both my education and my career and getting to work with some great folks and some amazing experiences that just feel very lucky with that. Obviously, Eric, you and I got introduced because of a mutual patient, even though we're across the state. Being able to make connections like that and to be able to collaborate makes this job a lot of fun because you end up meeting some really great people and learn something every step of the way from everybody in the process. And I feel very fortunate for that.
Awesome. Yeah, love it, love it. And I think I can speak for Christian as well. As therapists, we really enjoy having the surgeons who are responsive and respectful to what we do, and it really helps us out a lot being able to collaborate with you all as well. So, all right, going into the first set of questions. My first question for you, Dr. Gordon, is actually it's a little bit of a curveball. I wanted to start out with kind of a fun question here. I saw that you were a place kicker at University of Pennsylvania, and I'm not sure if you're familiar with the college game day experience that they do. Every Saturday, they pull out a random student to kick a 30-yard field goal. And so my question to you is, if you got picked out of a crowd right now, do you think you could make a 30-yard field goal first try?
Boy, that is a great question. And I think 20 years ago it would be a no-brainer, yes. A couple back injuries later, I'm not so sure my hamstring would stay attached. I would like to think I'd still be able to do it, but the odds are getting lower as I'm getting older. I think that's my best answer I can give you. But there was a time and a place where that would be pretty straightforward. Although I just saw the other day, I think they put $800,000 up. It
Yeah,
was like $1,000 went to charity and $200,000 went to two separate students. I'm like, that's a lot of pressure on a college kid to go out there who doesn't normally do that. And the kid hit it. So it was
yeah,
pretty cool to see.
yeah. I totally agree. That was a fun video to watch on repeat because that was pretty intense for sure.
It is also amazing to see how many balls are sprayed into the crowd. You didn't think it would be that dangerous to be standing there outside of college game day.
Yeah. No, absolutely. I agree. Yeah.
All right, I guess we'll go on to my questions now. On to the real stuff. So, Dr. Gordon, one thing that's really important to Eric and I, and part of why we started this podcast and this company in the first place, is we're always trying to improve at everything that we do. So, my question for you is, how do you hone your craft as a surgeon?
It's a good question. I think that one thing that happens with surgery and medicine in particular that I think is a dangerous part about it is that there's always shiny and new. And you always want to use the latest, greatest technology, the latest, greatest device, the latest, greatest technique. And I think early in my career, I was a little more excited about that. And I wanted to use that new screw that just came out that's going to resort better and become better bone. Or I wanted to use this graft because it's supposed to be better, and that's what somebody in a lab said, and then it gets promoted. One of my senior partners early on, and I would have some great talks, he challenged the heck out of me to make sure that I kept growing, and he was right. Sometimes latest greatest isn't the best, and I describe this to people that I don't always want to be in the front of the wave of innovation. I don't mind being on the backside of the wave. Let other people take credit, because when in the front of the wave, sometimes that wave crashes. And the trouble is that patients put a tremendous amount of responsibility on us to make good decisions for them, whether it be the screws we use to fix an ACL, whether it be the graft choice we use, whether it be should we fix the meniscus or take it out, do we need to augment for an ACL, things like that. And I've kind of fallen back into tried and true and the techniques that I know work well. Certainly I will modify them as things come out. I'm an admitted a big fan of patella tendon grafts for ACLs, for example. Yet, as Eric knows, we had to do a revision and use quad tendon graft, and I think I've got 2 or 3 ACLs on Monday, 2 of which are going to be, one's a revision, one's primary, and both wanted quad tendons. I'm like, okay with that. There's enough data now where I feel comfortable with it. And so, either you go to labs and cadaver labs and practice with the things, and to make sure you know what you're doing, or first time I ever did a hamstring repair on somebody about 18 years ago, we literally got a cadaver and went and dissected it out, because it's not anatomy that you spend a lot of time looking at in med school and residency, because it was kind of a new technique. And I had this impression or this idea in my head how I was going to do it. And then all of a sudden, I'm like, whoa, my plan is out the window. I'm glad we just did this. I'm a little bit careful with the literature, because I think the literature is all over the place. I've just traveled with Marquette basketball, and I took a bunch of my journals for the long flights, and I was just laughing as I was going through it, because there'd be competing articles. One saying this graft is the best, another one saying this graft fails more than the other ones, and literally they're side by side. So you kind of have to figure out, okay, literature's great, and it's wonderful to have the numerical backing for you, but what people really want to know is what works in your hands. And which is what I always say, look, we do second, third opinions a lot on patients, and I always want to be respectful of other clinicians, because certainly there's many different ways to do things. And I always come back to with our patients that in my hands, or in our hands, being the team that I get to work with, this is what has consistently worked for us. And so I try not to vary too much off that, because I've got 20 years of doing it. And, at this point, I know what techniques work for us and for our patients. And I don't want to deviate a lot. The other thing is that I've got some people that are fairly prominent that we operate on, whether it be some of the athletes from the university here, or we've operated on some of the UFC fighters, or some of the other professional athletes, and there's a lot of eyeballs on those folks. And that's not somebody that I want to be having anything but that I've got 100% confidence in the direction we're going. Now, it's a very long-winded answer. I don't mean to make it that complicated, but really it comes down to you figure out what works best for you and try and stick with it, then kind of modify as things change a little bit. There may be a newer fixation technique that you might like to utilize, and it makes sense, and so I don't mind trying that.
Oh, that's an awesome answer. There's a ton of gold in there. But one major theme I heard is that there's a lot of wisdom in restraint and focusing on what you know, but also just being open to change over time, just not being the first one to jump into it, because these are very real challenges, and it's important to do right by them.
100%. And it's fun to try new things. It's fun to look, who doesn't love getting a brand new cell phone? And all the newfangled things, or the new car that's got that huge screen and all the new things, the touch stuff. It's great, it's cool, it's fun, but you never buy the first generation of a new car, because they're still working the bugs out. And so I don't mind waiting a little bit.
Yeah, I love that answer. Thank you very much.
Yeah, thank you. I agree. That was a great answer. I think part of the reason why I love it is because like Christian and I talk about a lot, especially in PT, there's not a whole lot of black and white. There's a lot of gray area, and it takes a lot of discussion to really kind of wean out, especially with each patient being so individualized. So anyway, thank you for that great answer there, Dr. Gordon. My next question is, what part of rehab post ACL surgery do you feel is the most crucial to good success, both in the short and in long term?
I'm as we navigate the world of insurance of 20 visits post-op, or for a year, not even post-op, for a year, I'm very clear with our patients. The two most important months of rehab are the first month and the last month. So if you make the argument, and I tell our patients our recovery is 6 to 9 months. It used to be 6 months, everyone's supposed to be cleared, which I think is just nuts. Because you guys know from the rehab side, the average high school student that's got class load and maybe a job else is not going to be ready at 6 months, even though they're young and they recover faster than somebody my age would. That first month, super important, get the swelling out, get the range of motion back, get the quad control back. Excuse me, the last month is getting that final sport-specific training, the confidence and the more complex movement patterns. The stuff in the middle, they can do a lot of that on their own. No disrespect to my PT colleagues, and don't misinterpret the statement, but one reason why PT is so valuable is that you make the people do the exercises the hour that they're there. Because we ask people to do their home program, and I'm a back patient. I've had back issues, and I've slack all the time on my exercises. So I'm no better than my patients, but it's the reality of what happens. So I think that if you ask me what's the most important part, the first month and last month, but it's also you guys checking in along the way and being creative, changing the program enough so that the patients stay engaged and interested. Because you have me do the same bridges and the same mini squats for 3 months, I'm bored. Finding new ways to make it interesting. Or if it's a soccer player, how do you incorporate a soccer ball in some of the early exercises without risking the graft, but also allowing them to kind of feel connected?
Yeah, I totally agree. And just to further that point, to go off it just for a quick second, Christian and I discussed a clinical practice guideline around that as well. And they discussed the idea of improvements in ACL rehab, either supervised or non-supervised, or in the clinic and at home. And in that article, they said there's really no statistical difference if you're looking at a supervised rehab program, i.e. coming into the clinic, every week, or like you're talking about checking in and kind of revamping it throughout those middle months, that time period. No, great answer. I love that. The first month and the last month. That's great.
So going back to the surgery stuff itself, I know you go into surgery with a plan, but what are some of those game time decisions that you have to make while operating?
I mean, look, we try to go in with as much information as possible. We have a lot of technology going into surgery. You've got radiographs, you've got MRI scans. MRI scans are not perfect. They miss meniscus tears, they miss cartilage injuries. Excuse me. I think probably the biggest game time stuff really is going to be around. We talk about graft length mismatch a little bit, where particularly with patella tendon graft, that you're locked in with how long the patella tendon is going to be. And people have got super long patella tendons can make it tough, or what's even harder is a really short patella tendon. It's easy to work with a longer tendon, but a shorter one, that can be a challenge. We try to plan for that in advance. You look at x-rays, look at MRI scans to get impressions of that. In the era of doing hamstring grafts, sometimes you'd harvest the hamstring and you want a minimum of 7.5 to 8 millimeters in size, and all of a sudden it's 6. And you go, just not a big enough rope. And so there are some tricks you can come up to make it bigger and that kind of stuff. There's times when you harvest a graft and it doesn't come out quite the way, you hope it is going to come out. There's people that got really, really tight knees. And for example, when you operate on runners, they tend to have really tight knees. And if you're trying to fix a meniscus or trying to do a meniscectomy and getting into the back of the knee, it can be really tight. So you can do some little tricks to kind of release a little bit of the MCL. If we all know the MCLs tend to scar down pretty quickly on their own, but just you don't want to do damage. We're putting hard, rigid metal instruments into a knee with relatively softened surfaces, and the metal never loses. So, you don't want to do more damage to that. Those are the biggest things. And it's also just some of it's experience and just you see enough stuff that, I was very, very fortunate where I trained between Rush and the Baptist out in Boston. I trained with some phenomenal surgeons, some, industry leaders in decision making and innovation. And I'm a really good visual learner. Even if I wasn't technically doing the surgery, I was good at watching and seeing how they navigated some of those things. I can tell you I probably run into more surprises in shoulders than I do in knees. I think that there's the rotator cuff that you think is going to be mobile and it doesn't move. And how do I mobilize this? If I can't mobilize it, what's my next step? The labrum looks worse than we thought, or the biceps is not okay. Or there's all kinds of times you'll find a subscapularis tear that we didn't expect. And, we're pretty good at communicating with our patients and making sure that they understand what we're looking for and they understand that and they want us to address the pathology that we find at the time of surgery, even if it's not 100% what was directly discussed in advance. They're generally very grateful. If we say, look, we found this in there, it'd be an incomplete surgery not to address this while we're there. And so, you plan for surgery for an hour and a half, sometimes it's 2. And sometimes you're late for dinner. And it's just kind of the way that it works.
Yeah, that's super helpful. That just goes into experience, right? Like the more reps you get, the more problems you encounter and you have to come up with creative solutions or watch your mentors over the years. You just learn a lot of different things that are really important to get people better. And a lot of people probably know, but the best surgical outcomes come from the surgeons that do that thing more often because they just get those extra reps in.
Yeah, no question about that. I think that the total joint literature is really big on that, there's a certain number that you need to do in a year for your complication rate to be lower. In particular, total joints, there's so many registries following that. I'm sure it's true for almost every surgery we do, but they have the most data on that.
Great stuff there. Moving on to the next question, kind of going along with the PT side of it. So obviously the surgery is a big deal. Finding a good therapist can be a big deal as well. What do you think patients should look for when it comes to finding a physical therapist and being confident in their experience and having a good rehab process?
It's a great question. We're fortunate that we have a wonderful network of therapists we work with. And again, I've been doing it long enough, and I joined what was the oldest medical corporation in the state of Wisconsin was the Milwaukee Orthopedic Group that I joined. And so they already had some wonderful relationships with therapists, and we've been able to continue to grow that. One, there's got to be a connection. I mean, if the patient and the therapist personality-wise don't jibe, that just doesn't work. Because nobody wants to work hard and work through pain for somebody they don't like, trust, or want to be around. And that goes same with us as the surgeons. I'm a second or third opinion. I tell people all the time, I said, you're in great hands with somebody. Ultimately, go with the person that you're most comfortable with because you're going to do well no matter what. And I was going to start with this for you guys today. When I have conversations, particularly with ACLs, and again, we do get to talk to a lot of families, a lot of teenagers that have an ACL injury. My speech is almost always the same at the end because you're sitting there, mom and dad are in the room. There's a teenager that's scared. They know this is a year recovery, basically, that they're going to be out. It's 6 to 9 months, but really it's a full season that they're going to miss. And I always say is that the most important determinant of your outcome is the person sitting on the exam table. It's the patient. If you have a motivated patient, they're going to do well. If you have a patient that has zero interest in getting better, it's going to be a struggle. So the second most important group of people is the parents or the family and the support structure. Because if they can help them through the emotional phase, that's great because that's such a hard part. The third most important is the PT. And the fourth is us. I'll spend an hour and a half potentially, reconstructing somebody's knee and we think we do a good job. But quite honestly, people who do bad jobs, and I'm not throwing stones at anybody because I got people where I'm not always happy with their outcomes, but you see the graft is supposed to go one way and it's literally 30, 40 degrees off where you think it goes. Those folks still do well because they're really motivated patients, great support, and great rehab. So I think, how do you find the great rehab? One, you hear about in the community, you talk to the friends, you see, what you find pretty quickly, and I'm sure it works in both of your guys' worlds, where you're located, is that there are patients of yours that you're getting referrals because somebody got hurt that knows one of your patients, and those patients say, you have to go see Eric. Christian's the only guy you can go see. And that is the most powerful statement. One, to build instant trust for that person, something that they trust and know recommends you. And two is you're not just getting pulled out of an insurance book, that you're the next name on the list. And I think that, that word of mouth part is important. I'm a big believer on manual therapists in the sense that you put your hands on people. It's not just do these 8 exercises, because if you only got 45 minutes with a patient and you can do that for 20 visits, teach them how to do the exercise, but for the most time there, help them move the tissue, watch them do some movement patterns and work through that, and then give them the exercises they need to. And I think when you find therapists that do it that way, that's the home runs you want to be around. And so, again, another long-winded answer, but I really believe word of mouth is a big thing. I think a partnership with some of the surgeons that you work with that, will say, hey, I want you to go see this person. And I used to get yelled at all the time by one of the clinic directors in one of the suburbs because I would have a young athlete and I could just read personality, and I'm like, this personality is going to do great with this one therapist. So I'd say, hey, you need to call and get on this person's schedule. Well, I would get a call from the clinic director, hey, Mike, this individual's really busy. We've got like 6 other great therapists. And I said, I get it, but I know this therapist and this patient, and you know what happens? That patient's family is ecstatic that we have a relationship with the therapist. They know we have an open line of communication. Now, the reality of what we do for a living is I see a patient once a month. You see them twice a week. Who knows the patient's better? Who knows their progress better? Who knows if all of a sudden their girlfriend or boyfriend had just broke up with them? Who knows if their grandfather just passed away? And the emotional state part of it. You guys are the eyes and ears of what we do. So to be able to find somebody that has a connection with the physician they're working with, and by the way, it's a two-way street. My number one referral source is PTs and ATs. And I will tell you, for me personally, it's a very humbling part of what we do, that the people who see our outcomes recommend the patients that they care about or their family members to us. And we're not the only ones. There's other docs they refer to, I'm sure, but it's a very humbling part of what we do. And so I think that finding that kind of connection for patients, and I don't always know how easy it is for them to find that, but I think that's really important.
I got nothing to add on to that. I think that was a great answer all around. I love the part about the connection and building that trust and knowing that, the person you're going to see is, you have that prior knowledge of, hey, this person I already trust recommended them. And they go into that experience with that previous thought, which is a positive one, right?
Eric, and a follow-up on that, again, how we met is through our combined patient, who's a phenomenal young man, working extremely hard with some big injuries, and knowing the confidence he had with you and how well you communicated with us. I mean, it made this easy. And in particular, in this family, there happens to be another person, a rehab person in the family. So understand, what's going to be good rehab, what's going to be communications needed. And I mean, it makes it fun. Like, I mean, there are patients that I worry about because I don't know the rehab people they're with. And we did a big surgery on, and I tell from my nurse practitioner, who's an athletic trainer by trade, initially, we have to kind of hawkishly look over what's going on, versus when I didn't worry about what our patient was doing. I don't worry about what our patients are doing with the therapist that I know in town, because they're in great hands, and they're not going to, have them start doing box jumps at a month after an ACL. Like, I don't have to worry about, because, they've progressed past this point, we can do this now, without understanding that, hey, I'm a really conservative doc and I'm not going to push fast. I want to go slow, because you never go backwards.
Right. Yeah, no, thank you for that. Yeah. Yeah. It's kind of funny. My girlfriend will be like, why are you texting a doctor at, 9:00 at night? Like, don't you want to put your phone down and go to bed? And you mentioned the idea of being fun. And it's like, well, yeah, I do want to, put it away, but I mean, I'm kind of eager to send this text out or communicate about a patient, because it is fun. It's an enjoyable process.
It's why we do this, guys. It's great to be able to provide for our families and everything else like that with making a living. The fun part is watching the again, I'll use our young guy as an example, fight to get back. Unfortunately, had a setback, as you know, and see how excited he was. He's moving forward. For me, I'll use directly, like with taking care of the university in town here, watching these kids go out there and play. Like, there's a certain amount, inside, I'm not jumping up and down, but I get a big smile going, wow, how cool is it that all their hard work paid off? Again, I play such a small role in that, but to see them kind of their personalities come out, and them, be so happy, be able to enjoy the sport that they play. it's the best feeling.
Yeah, I know you just said that you feel like you play such a small role in that, but I don't know. I feel like you play a massive role in just like setting the stage and setting people up for success because it's probably very similar in Milwaukee as it is in Portland, but word of mouth is huge here. It's just so small. Like when the PTs know the surgeons and vice versa, and like we're all talking good stuff about each other, the patients latch onto that. And that just like immediately, like you said earlier, like if you know who you're working with, you just feel so much more trust in those people. And so even if you might see them for that hour and a half once in a while, it means a lot if they feel like you're on their side and you're treating them as a person. And that's just crazy important. All right, so moving on to the next question. Eric and I talked about those guidelines about ACL reconstruction rehab and just how difficult it is, how much of a bear all this different stuff is for various reasons like the quad shutdown and motor control issues, all that stuff. But from a surgeon's perspective, what makes the recovery after ACL surgery so difficult?
It's a good question. I guess I'm going to give you another long-winded answer. I'm becoming very good at that.
Those are always encouraged.
Well, first off, it's a big surgery. If you do a patella tendon graft, you end up with a 2.5-inch incision in the front of the knee, and you're drilling holes in people. You're taking one part, moving it to another part. People don't like holes drilled in them. It hurts. They end up with a swollen knee. There's pain. There's stiffness. We all know that there's the first thing I learned in orthopedic school. I've never forgotten this. The first lecture we had was from Brian Cole, quite honestly. I'll throw his name out there from down at Rush. And they was talking about the reflex arc with a swollen knee shuts down your quad. A small effusion makes it hard to fully engage your quad. Well, now fill the whole knee up with blood. And, because when you drill holes in the bone, even though you're filling it, there's still some exposed bone. And so there's going to be some bleeding that oftentimes just stop because of tamponades. Well, that becomes a big swollen knee. That means it's hard to fire the quad. So I think that's part of it. I think the other thing is that ACL tears don't hurt that much when they happen. I think it's interesting when somebody breaks their ankle, they hurt like crazy. So when you do surgery on them and you make it so the bones stop moving by each other, even though you put a plate on, you make an incision, it hurts post-op, but you're trading one pain for another one. And it's almost like when you do a knee replacement on somebody with really horrific arthritis and they're barely getting around, you trade a 5 to 6 out of 10 for 9 to 10 out of 10 pain for a couple days, but you're not going 0 to 10 out of 10. And so people adapt to that better. I think oftentimes the ACL patients are younger. This is a new experience for them. They're not used to it, and they're not used to the drugs we use. They're not used to that level of pain. They're not used to the loss of independence. I can tell you when I went off to college, I spent several months on crutches with a knee immobilizer, and I really struggled emotionally with it because my outlet was going out and playing soccer, and I couldn't do any of that. And my stress was building up being a college freshman in the middle of West Philadelphia, surrounded by all these really, really bright private school kids, and I'm just a dumb public school kid from suburbs of Milwaukee. So I think all of that plays a part in it. And I also think the fact that everyone knows it's a long rehab. It's 6 to 9 months, and I always joke with our patients, but I'm semi-serious. I said I give them a week of woe is me. You're right. I feel terrible for you for a week after surgery, but after that, it's game on. What got you to be such a good athlete? That commitment you are now going to commit towards your rehab. And if you're having bad days, pick up your phone and call me. 99% of my patients that we operate on, actually all of them have my phone number. So if they have issues, I don't really want to get called at 2 o'clock in the morning, but I get texts at times and it's like, hey, we don't just take care of the joint we operate on. We're responsible for the whole body. That includes the mind. And sometimes we're not the right people. Sometimes it's conversation with families like, hey, have we talked about getting involved with a psychologist? Or the therapist will contact me and said, hey, this person's really struggling. They're kind of expressing this stuff to me. And like, okay, what can we do to help? So I think it's that whole combination of stuff. And I do think it's a daunting rehab. It's long. You do a meniscectomy on somebody, they love me the next day. You take away their pain and they're walking on it the next day. When you have an ACL, you're going to have limited weight bearing. You're wearing a brace. And I'm cruel to my young patients. My college students that I operate on, I'll tell them that, they should wear their big post-op brace up to 6 months if they're going to go out to a party. You guys remember being at a college party in a basement of somebody's house with a bunch of, 100 drunk people in a small room? They're on a slippery floor. I mean, and it takes one dumb move when you're not prepared for it. So I'll be the bad guy and say, hey, but it's a daunting recovery. Long answer again. Sorry.
No, you touched on so many good and just like real things that people need to hear. It's it takes over your life. It definitely messes up with your independence. And I just like to make sure that people are more prepared for that because I feel like, I don't know, there's just like this misconception around here that, oh, I'm going to go into surgery and the surgeon's going to fix me and I'm going to go cruise through this rehab. It'll be totally uneventful. And it's never that way. And almost every single person I work with is kind of surprised about that, despite me trying to warn them. And I think it starts with the surgeons too, just making sure that you're having that honest conversation. I'm just really happy to hear that you do.
Christian, you just said something actually that is one of the things that I find the scariest of what we do. People come to surgeons because surgery fixes things. It's a really dangerous concept because there's nothing I can't make worse with surgery. And that's the philosophy I've been taught to live by. So if we make a decision to do surgery with somebody, it's because we're weighing risks and benefits. And ultimately, between my nurse practitioner, who is an incredible healthcare provider, and then we work in partnership really closely, and we feel like, okay, this is the appropriate person and we can help the person by doing this. But God forbid things don't go the way we expect, or whether it be infection or they fall post-op, they slip because we live in Wisconsin, it gets slippery and they tear their graft, or they break their patella because they fall on it after surgery. These disaster things that can happen. We want to make sure we have the justification that we're doing the right thing. People come to us in desperate states at times, and we look at them like, look, I know you think surgery is going to fix this problem. It's not going to. I'm happy to operate on you, but I don't think our chances of getting the outcome you're looking for is there. And so I have to respectfully say, I don't think it's a good idea. And sometimes they'll find somebody else that is happy to jump in and do it, and that's fine. That doesn't mean that doctor's wrong and I'm right. But again, in our estimation and in our comfort level, that's the way we look at it. But, I have the same trepidation when I take my car into the auto repair shop when it's got the check engine light and I hear this horrible sound, as people do come into my office. I expect them to fix it. The difference is if my car's unfixable, I can go buy a new one. Difference when they come to us and they want us to fix something, we can do some stuff to help. But I don't know if I can fix the problem fully sometimes, and we have to be honest about that.
A lot of wise words there, I think, Dr. Gordon. So thank you again. Like we've been talking about, we know that the post-op ACL isn't always perfect. Things can come up. Just I guess in general, if you do have a patient that has a setback post-operatively, what are one or two things that you might tell them or communicate to them when they hit that bump in the road in their rehab process to, maybe calm their mind or give some optimism on the road ahead? What are some things that you might tell your patients, Dr. Gordon?
One of the most important things I learned from, again, one of my senior partners when I first joined, and I was very, very fortunate when I came to Milwaukee. I joined a bunch of high moral, incredibly talented surgeons who were phenomenal mentors. What's interesting about training in you go to med school, you learn a vocabulary. You go to residency, you try not to kill people, and you learn techniques, but you don't really know how to apply them yet. And then you hone those techniques in your fellowship. And for me, my fellowship was great because I wanted to get more experience covering sports. We took care of the Celtics. I had an amazing experience out there with that. But then you come into practice and you have real life patients that come to see you, and you can't figure out why they're seeing you. Like, I just moved here, and like you don't know me. I have no reputation in this community, and I would talk to my senior partners all the time. Hey, does this make sense as the next step? Like, I thought I had a good plan, but just to confirm it. And my partners were always really open. But one of my partners was very clear. He's like, whatever you do in your career, don't ever bury your head in the sand. If you think something isn't right, don't say, oh, it's probably okay, but I don't want to look. Make sure that you address it head on. So, like, for example, our patient, something didn't feel right, something changed, do the workup. Get the information. And I'm also very clear with patients. People can panic. People can be really upset. I said, we don't have the facts yet. Get the facts. Let's make decisions based on facts. And then we may have to do something more, or we may just be able to watch this. And that goes for every part of medicine. I have a family member that unfortunately had a mass they found, and everyone's panicking. And I said, you know what? It could be horrible. You don't know yet. So before we start getting all down that pathway and, making new life plans, let the testing go out, figure out what the plan is, and then move forward. And sometimes you get horrible news. And you have to be open and honest with people. And I think one area we're very fortunate is that we spend a lot of time with our patients, and there's a tremendous relationship we have with our patients. And we have open conversations, and some get mad at us. When people don't have the outcomes that they expect or we expect, sometimes people want to blame somebody for it. And unfortunately, my name is the bottom of the piece of paper. I tell everyone in the operating room, I'll tell the rehab people we work with, if things don't go well, ultimately I will take responsibility for it, because I hate the term captain of the ship, but ultimately people will look to the surgeons on being responsible, despite the fact that your guys' role is probably more important than mine. But I think it's really important that you have that open conversation, and generally people are understanding. I will tell you, I can't name the last 10 patients that had great outcomes, but I can tell you the 5 of mine that had complications. And the part that's craziest to me is some of the biggest complications I've had, those are the weddings I'm invited to, because they recognize that we really care. Like, I'm very empathetic. I don't think we do anything wrong with these things, and I have no problem telling them, like, I feel horrible the way this turned out. This was not our expectation. That's not saying we did anything wrong, but we all had the expectation things were going to go well. And that's a hard thing to do in medicine, because everyone's so worried about the legal side of it. I'm not doing it to decide anything wrong. I'm saying, hey, I'm an empathetic human being. You're a human being across from me. This is a struggle. This is not what you wanted, nor is it what we expected. Let's help navigate through this. And if the relationship is broken and I'm not the person to help with it, let me get you in the hands of somebody we trust to help navigate that. And generally, patients are extremely appreciative. You say, look, this is no longer my area. Let me get you in the hands of somebody that's going to be the right person to get a solution. And is it swallowing a little pride sometimes you do that? Sometimes the reality is it's often just saying, hey, I'm doing the right thing.
That's a great answer. I think you mentioned the word empathy a couple of times there. And another word that came to my mind too is just honesty, right? Like you said, not burying your head in the sand and being honest with people. And I think that's really important, even in, especially in PT, like working with someone with like low back pain, right? And, if we're not getting the outcomes we want in physical therapy, being honest with them about the plan of care and where it's going and the original thought and just all that stuff kind of like just resonate with what you said there, Dr. Gordon, having that piece of honesty with the patients as well. And I think they're always very appreciative of that honesty.
It's a hard part in medicine. I think that we all struggle with it a little, because there's always this fear of the medical legal ramifications of things. And I guess we have that, but I'm a relationship person. I haven't been on time in my office in 21 years because I talk too much with our patients. And, it's great that you have a knee injury, but hey, what's going on with the family? What's happening? And, your dog just, you have to put your dog down today. Well, that's going to affect your knee. So knowing this stuff influences how we move forward, because I know they're going to hurt more after that. And being able to build a relationship with people is not because I'm trying to protect myself legally. It's because I actually enjoy my job a lot more if I know what's going on. I mean, again, you see it with the family we're talking to. I get a text message from the family every now and then about things, what's going on, and checking in on things, and it's great.
Absolutely.
Yeah, and I think people just love when their physician or clinician is just a real person. You're just like, you're there, you know about them, you know their family, you know their struggles. They know you, they know your family, all the stuff you're into. It makes for a much better experience. And frankly, I think you get better outcomes when you do all that stuff really well.
100%.
I've just seen it so many times over the years.
The problem with what we do is healthcare is becoming more and more of a business. What's happening is, and this is not being a little bit more political than I probably should be, but as healthcare is moving into more system driven, you become more and more of a person who makes widgets on the line. And it's completely understandable how it happens, because you're an RVU generator and you have administrators who don't know what you do for a living telling you how to do your job. And that affects that relationship somewhat. And it's sad, because I do think it's breaking down a little bit of that relationship, and we're fighting against it staying independent. And it doesn't mean, by the way, there's not great physicians in the systems. I don't want to say that, because I've got great friends and great colleagues that I refer to all the time that do amazing work for their patients. But you can just see how the pressures are different, and the structure is different. And different isn't always bad, but I just think that healthcare has become more of a business. It's more transactional and less relationship. And healthcare used to be run by nuns, rabbis, doctors, nurses. Now it's by MBAs and CEOs. And it doesn't necessarily mean that it's a bad change on some levels, because it is so much part of our economy, but sometimes you lose a little bit of the heart part of it that we went into it for that reason.
Yeah. And something you said earlier about manual therapy for physical therapists, getting your hands on people, you're seeing a lot of that go by the wayside because, the research says that stuff doesn't really help you so much in the long term. And people don't really want to put the time and effort into learning how to do those things really well, or they can just get their visits, they can get their paycheck by doing 2 times a week for 6 weeks of just exercises. And it's just, I just don't think it's doing it. I think you need a bit of that hybrid approach, and people really appreciate that.
And honestly, the manual therapy approach also is, I think, another big benefit. You're touching the patient. You're making a connection. I joke about this all the time with people when I talk to high school kids thinking about going into medicine. And I say, I ask people to come to my office. We make them wear ill-fitting clothes, weird size shorts and maybe a tank top or something, depending on I'm looking at shoulder. They know I'm going to touch them. I'm going to ask really personal questions about their drinking history, their drug history. Sometimes you had to ask some of their sexual history. I know all the medicines they take. I know maybe some diagnoses they don't want people to know about. And then instantly they're okay with me, grabbing their leg and moving around and poking and prodding. Now, next time you go out to a bar, the person you sit next to, ask all those questions and start poking and prodding and see how long it takes before you get slapped. Because there's this instant trust and connection you make with that. And so I think that if you guys just sit there and point on exercise and demonstrate exercises, that's lovely, and it's a knowledge base you have. But I think when you get down and you help and you take your hands and you work through the swelling in the knee, and you help to, efflux, I've got the terminology, to help push out some of the swelling and to help mobilize some of the tissue. I mean, you're building a bond with that person because they built a trust with you that I think that you don't get without that component of it.
Yeah, and especially like you said, the first month of rehab, like the stuff you're doing isn't complicated. Almost all of it can be done on your own at home. So like, let's use some of our time to help you with those things, make your knee feel a bit better, get some of that swelling out, and yeah, just make you have better outcomes that way.
A lot of really good stuff in there. My last question for you is kind of a little bit more of a broad question, but you've had experiences working with professional athletes that, like you've mentioned a couple. What have you learned? Some lessons you've learned from the professional athletes from getting to work with them?
Good question. I'll be very careful how I answer this one. I was fortunate. I was with the Bucks for a good portion of my career. And I've also been very fortunate that I've been working with the university, with Marquette, and I'm incredibly grateful for the experiences and the opportunities. There was an amazing juxtaposition of seeing college athletes on one day and then professional athletes the next day. Now, college is getting a little bit different with the money that's going in now for athletes, and that's a whole other discussion. But the motivation with the college athletes was different. The drive was different. The amount of recovery and rehab that is available for professional athletes is nuts. If a professional athlete tears an ACL, they may get 6 hours of therapy a day, 7 days a week. Average insurance plan gives 20 visits of about 45 minutes for a year. So if you get in a car accident in January, I hope to God you don't get hurt in September, because you ain't going to have any visits left. So I think that part is real. I think that the tools available to them from nutrition, some of the mental health stuff is amazing, and it does make a difference. So that part is different. What doesn't change is the injury is the same injury. If a high school student tears their ACL and a professional athlete tears their ACL, the surgery itself, you don't want to all of a sudden change what you do. You know what works. You have to rely on that to do it. And I think sometimes it's easy to speed things up in your head and keep going. And I think what I've discovered after doing this now long enough, that there's the old saying when you're in a hospital and there's a code called the first pulse you check is your own. because don't go sprint there and be all, scatterbrained. When all of a sudden you see somebody down, you make sure that you're calm and ready to think clear through it. So if I got to go down the court and take somebody off and go to the locker room with them, walk, get my mind around what I think is going on, and have the conversation. I've learned a lot over all the years. I mean, the biggest two learning experiences probably were with the Bucks. One was Andrew Bogut's arm injury, and if you guys remember, Andrew went up for a dunk, slightly touched from behind from one of the Phoenix Suns players, and landed awkwardly. And I'm not giving news out. I mean, he had a multi-joint injury to his arm, and it was chaotic. Yet one or two of us had to be calm walking through, because the injury, it's a person worth a lot of money that's injured, and there's a lot at stake, but the injury is still the same, and you still have to walk through the process the same. The other one was one of my all-time favorite players I've ever taken care of, and somebody I consider a friend, which is Carlos Delfino. Carlos went up for a rebound in a game, got knocked down, and was laying face first, and one of the other team's players stepped on his neck. And I love Carlos, and his nickname is Cabeza because he has a ginormous head. So basically what happened is, between his chin and his chest, when somebody stepped in his neck took a fair amount of abuse, and Carlos wasn't moving. And, looking at a guy laying on a court with TV cameras everywhere, and I get called out in the court to walk through it. Again, I don't want a pat in the back. I don't want anything but just, hey, what are we doing to make sure he's safe and make sure we're not doing something that's going to make him worse? And then how do we get him off the court to get the workup done? And we're on the court for about 10 minutes. And I'm forever grateful for one of the officials who is, I'm not going to name, but was not always the most loved by people. And he whispered in my ear as I was down on the court, he goes, "Doc, you're doing a great job. Take all the time you need." And I've never forgotten that. It's like, okay, he's right. Slow down, because it's a neck injury. Whether it's somebody from a car accident, whether it's one of my older patients that falls down, or whether it's a guy with millions of people watching, you have to treat the injury and take yourself out of the situation. Now, you may go home and have, racing heart rate a little bit, like, I can't believe what just happened. And, we always did a decompression conversation with people. Hey, what would we do different? But that's the biggest thing I've learned, and I've been able to have some amazing experiences. There's nothing like going to a opposing team's arena and winning a playoff game. That's the best. Shutting up the fans there who are just abusing you. I don't know how many times I've been on the kiss cam, sitting next to the medical doc. You just sit there, look at the floor, waiting for the kiss cam. I mean, just because you're just getting embarrassed when you're there. But it is, those cool experiences, getting to know those guys as people. And what was really special for me with the Bucks is that when, it was always inconvenient when, they would get hurt. They'd come to my office when I was convenient for them, not always for us. And sometimes it was disruptive to my other patients. But to a person, anytime I asked one of the guys from the team if they would be willing to talk to an athlete of mine, or if they'd be willing to sign something, I still remember I had a young high school student. He was 15 years old, ended up tearing both of his ACLs over 2 years, and pretty down. Still, my players, Luke Richard Bamute, was coming through the office for something, and Luke was a really smart guy, very nice guy. And it happened to be that my young patient had seen him walking through the office, like, was that a Bucks player? I said, let me go check. I didn't know he was coming. So I look out there, and it's Luke, and I said, hey, Luke, do you mind saying hi to this young guy? He's having a rough go of it. And he's like, of course, Doc. He went in there, and for 15 minutes they talked about international soccer. And it made the kid's day. And, in a small way, my relationship and the sacrifice we made for the team made that kid's recovery from his injuries better. And so I feel very fortunate and blessed to have had those opportunities, despite the fact that I probably developed an ulcer and aged 15 years doing that job.
No, yeah, those
fighters is horrible, because whatever you operate on is the first thing the person that they're fighting attacks, and that's awful to watch. I covered one or two of the fights as for one of our fighters, and I won't do that one again, because it's too hard to watch that. I didn't go into business to watch people try and get choked out, broken, or dislocated. That's just not what I'm interested in. Otherwise, it's really fun. We're really lucky to get a chance to watch our folks go out there and hopefully excel and achieve at what they've worked so hard for. And again, that we get to play a small role in it. And whether it's the professional folks who aren't always the most communicative and grateful, versus the college folks who are wonderful, And the high school kids, or they don't even have to be high-level athletes. It can be the mom who does jazzercise that often go down and go on the ski trip with her kids. And, we're really lucky with that.
I feel like I could sit here and listen to these stories all day long. So thank you for that.
I appreciate it. Honestly, guys, very lucky. And again, I would say that we get more credit than we deserve as the docs on this, on the surgeon, the doctor, whatever you want to call us in this thing. It's a group effort always. And if anybody doesn't recognize that, they're being arrogant and not realizing what goes into people's recovery. And all those different phases matter. Professional athletes have more access to it. Sometimes they need it because they're less motivated. People don't do well without a whole team around them. And, we're lucky to work with good people. They make us look really smart. And I do not ever want to take that for granted because I feel very fortunate to have had the relationships I have with the people. And that helped me be successful. And quite honestly, I like hearing from the therapist. There's like, hey, Mike, your shoulder patient, they're really struggling. Did you do something different this time? Because we've seen this, this, and this. And it's really cool feedback to have. I think we become better because of it.
Yeah, no, thank you for everything. I know this podcast went a little bit longer than what might have been suspected initially, but I think it was all wonderful information that you provided us and some great conversations. So thank you again for coming on here and giving us part of your day on a weekend when, I'm sure outside of this, you have a very busy life. So we really appreciate it.
Happy to help, guys. Thanks for including me in this, and thanks for the efforts you all make for our patients. It does not go unnoticed.